highlights of this in the news because I think it's important, which is the CMS inpatient only procedure list is going away. It's been around for 20 years, and you're talking about 1,740 surgeries that would have been automatic inpatient. You wouldn't have necessarily had to worry about the 2 midnight rule, and they would have been MSDRGs. A large portion of those in shorter stays with healthier patients may now be getting billed, and we'll see this in a second, under ambulatory payment classifications instead of MSDRGs. And I'm a little bit worried about, what the downstream effects of that may be. There's been no pilot program. The only thing you do is look at commercial insurances that allow this, or Medicare Advantage actually allows it, and try to get an idea of sort of how that workflow is. It's going to be kind of a big hit, I think, once this is a situation where, it's now possibly payable as a Part B and not necessarily just as a Medicare Part A only. The dates. So 200, most of you probably know, 266 roughly of these already were moved off of the inpatient only list as of January the 1st. The list is going away, or it's scheduled to go away completely September the 30th. There's a 2-year moratorium on audit activity that expires September 30th of 2025. Now, I don't know if they'll be able to backdate that. Sometimes that's when the audit activity can start, but they may be able to look back 6 months, a year. They may be even look back all the way to the go live date. I think I doubt that, but don't take my word for that. I just don't know. But I think we need to make sure that we're getting these 2 midnight rules and we're getting them on the correct status, whether it's going to be an APC or an MSDRG right off the bat. And this is going to impact coding, obviously, and CDI as we move these patients around. So some of the things that I'm worried about, I mentioned this, the case mix index may go down if a significant portion of your surgical population is now not inpatient status. The APCs will go up. Now, as far as if you're a revenue type person, are those going to intersect at a break-even point? Industry experts think that that's going to result in roughly a 3 to 10% loss for the facility in this population. I heard one estimate, don't freak out, that was up to 57%. I don't think we'll see those kind of numbers. That's a statistical worst case scenario, but it is still something that needs to be sort of in the back of the mind as we careen towards 2023. A lot of the ones, though, who have major surgeries such as open chest, brain, GI, older patients with a lot of comorbid conditions, that's business as usual because they're going to require more than 2 midnights. The difference is you have to make sure the documentation is clear that they're going to require more than 2 midnights. It's not automatic anymore. The shorter stays, though, those are the ones that'll shift. Cases with unexpected complications that we thought might be OBS then shift back. And so we're going to have a lot of midstream. Those are the ones that worry me. They start out as OBS, we're billing them, we're thinking it's APC, then they shift, the coding rules change, in the middle of the stay, suddenly they're an inpatient, the charging's different, the coding might be different, the CDI may need to suddenly get involved. I just think that there's some things that we should start thinking about now. The same surgery might be inpatient for a healthy, inpatient for a 90-year-old patient who has hypertension, diabetes, and morbid obesity. But for a 65-year-old who is still a marathon runner, maybe an outpatient. So you can't even go by the procedure code, what the expected procedure, because it's going to vary based on a case-by-case individual health status. Patient responsibility, this one really worries me. Flat rate of $1,484 for an MSDRG up to 6 months. But now they might get 20% with a cap of $1,484 in multiple categories, so they could get hit with a maximum of $1,484 for the surgery, for the transfusions, for the pro fees, and then get hit with all the pharmacy. So what used to be a $1,484 flat rate can now be, for the patient's responsibility, $6, $7, $8. Wouldn't surprise me if that could hit $10,000 if you had expensive drugs given. So this now is going to transition to patient responsibility and or a lot of collections activity on the part of the hospital, and that's going to be something to consider. Some people say, well, that means it's cheaper, right? But no, it's the same surgery, same lab, same drugs, same OR suite, same staff, same recovery. What's different is the bill. And that patient responsibility, having all these things added up cumulatively. What's going to be different? Their reimbursement. It's going to come in at less because of that patient responsibility. So budgeting, I think we'll start having these conversations at the CFO and Director of Patient Revenue level, which I know a lot of us are just sort of very much so focused on the coding and CDI, but remember, everything that affects one part of the health system affects every other part of the health system too. So, again, standard service model for the elderly, seriously ill patients. The pre-op planning may be a little different just to make sure that that's documented and make sure there's not some chance they could be OBS. But CMS likes to say that this is going to be reduced Medicare cost burden and it protects the Medicare trust fund. I'm sure it will. They like to say that it increased cost sharing between patient and provider, which is a nice way of saying that we're all probably going to get slammed here. And it incentivizes efforts to drive down cost. Yes, I think that's probably valid because the only way to do this and keep it profitable is going to be to reduce costs somehow and streamline the process and get them in, keep them healthy, and get them out and keep them healthy after they go home as well. Anybody who crashes and was OBS and didn't have the 3-day qualifying stay, that's not going away after the PHE. After the PHE extends, you'll still be on the hook for that SNF, or if they need home health care, they're going to get reimbursed at much lower rates because they didn't have the inpatient stay, all kinds of things. And then what happens if you just don't have anywhere to send them at all, but they were never admitted? A lot of case management stuff, I know, but some of you probably have backgrounds in case management. And some of you could probably even speak to it better than I can. So we just need to start thinking now in terms of mitigating this and reducing these revenue changes. What part is the coding, charging, documentation improvement, billing? How are we getting hit? How are we going to need to communicate with case managers going forward? Is there anything we need to do to help with that medical necessity to midnight rule piece? Are the orders being written correctly? With the coders, oftentimes we're going to double check that. A lot of moving pieces that I think to get to this bottom line, which is how is this going to further impact the facility's budget? All of us right now want to be as valuable as we possibly can and do whatever we can to help the facilities, even if it's slightly out of our comfort zone. Either way, this is an interesting piece of news. Some people say this might impact healthcare as much or more as when the MSDRGs came online back in 2008. We went from a 2-tiered system to a 3-tiered system. So I've got some further reading. Some of you are wondering where did Alan get his 3 to 10% or his 57%? Where are we getting some of these things? And right now, it's just a lot of it is just conversation from subject matter experts who are in the revenue area, who are reading, interpreting, and or writing this. So all of these are very interesting pieces, highly recommended for additional reading. So I also have this piece in here that I'm not going to spend a lot of time because we have this excellent panel, and I really want to get to that. But when we're talking about quality, and we're talking about getting 100% of our documentation of these risk variables on even healthy patients, that's when you really have to change your way of thinking. It's not just targeted anymore. You really need to focus on being sensitive to what types of patients that are coming through and what's actually wrong with them that we're missing, deferring to the experts in those things, working with your quality department, being able to pivot from one type of thinking to another. That's the resilience that actually ties into the 3-day rule, the inpatient only procedure list as well. And just a preoccupation with failure is one of my favorite things. Always be thinking about, could something else have explained this? And is there something we can do now to prevent something in the future? Always be thinking that way. A lot of health systems are way too reactive and not proactive enough, and then you get caught out, and you need help. So here's some information about the podcast, which we haven't really talked about, but Amy and I have a podcast that we do. Well, let's say we do it anywhere from once a week to once a month. It just depends on whether we're doing these webinars and what else is going on. We try to do at least 1 or 2 a month. Fun stuff. It's not formal. It's not a webinar. It's just us complaining about. And if you don't like complaining, join anyway, and you can complain about our complaining. You can come and argue with us. But talking about how coding guidelines don't always match up to realities and how things are out of sync or constantly changing. There's a lot of good information, I will say, that comes out of those. And then we have both of our LinkedIn profiles if you want to make sure you catch it whenever we share that information. Might be a little easier than just looking randomly to see if one's been posted.